Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Rida, and today I'm joined by the person whose sole job is to keep us focused, calm, and not spiraling, Maryam.
Hey everyone, I'm here to make sure nobody zones out and nobody says, it's fine, I'll just memorize this later, because later never comes.
Painfully accurate. And today's episode is all about bowel obstruction, a topic that looks brutal on slides, sounds scary in the ER, but actually makes a lot of sense once you slow it down and follow the logic. So, imagine this. A patient walks into the emergency department with abdominal pain. They're bloated, nauseous, and look uncomfortable. They haven't passed stool in days. The nurse adds they have been vomiting.
Hmm, this must be a bowel obstruction.
Before we even touch imaging, labs, or management, what does that actually mean, Maryam?
Bowel obstruction sounds like one single diagnosis, but it's not. It's a whole family of problems that all end in the same place. Things inside the gut can't move forward the way they're supposed to.
I see. So today we're answering three big questions. What is it? Why does it happen? And how do we recognize and manage it? Let's start simple, like exam definition simple.
Okay, so bowel obstruction means intestinal contents cannot move forward normally.
I'm listening.
Think of the bowel like a really long conveyor belt. Food, fluid, digestive juices, and gas are all supposed to move smoothly from one end to another. A bowel obstruction is basically putting a roadblock somewhere along that belt.
And what's important is this: the problem isn't just food backing up, it continues to give us a cascade of other problems.
You're absolutely right. It's pressure, fluid shifts, blood flow, and even bacteria, which is why this topic shows up everywhere: surgery, medicine, radiology, and exams.
Since it's such a broad topic, there are bound to be different types, right?
Absolutely. There are two main types of bowel obstruction: mechanical and functional.
Mechanical, from the name itself, would mean that there is a physical blockage, so something is in the way while the bowels themselves are working fine.
Yes, and since the bowels are fine, peristalsis continues, and sometimes even work overtime and slam into the blockage. Now, functional obstruction is just the opposite of that.
So there's no physical blockage at all.
The bowel just isn't moving. Examples include paralytic ileus, gastroparesis, and colonic pseudo-obstruction, also called Ogilvy syndrome.
Whoa ho ho, those names came out of nowhere, but don't worry, we shall explain them very soon. So, we know the definition of a mechanical obstruction, but it cannot just be one thing.
Exactly, it's a category. Mechanical obstruction can be classified based on where the problem originates: outside the bowel, within the bowel wall, or inside the lumen.
Sounds nice, but let's get a bit more medical.
Outside the bowel wall is termed as extramural. That includes adhesions, hernias, tumors compressing from the outside, and volvulus.
Then we have intramural, which means within the bowel wall itself. Think tumors, inflammatory structures from Crohn's disease, ischemic strictures, or post radiation fibrosis.
And finally, intraluminal, inside the lumen. This could be fecal impaction, foreign bodies, gallstone ileus, or even intussusception.
So, mechanical obstruction isn't one diagnosis, it's a framework. I have a question. Since we have so many different causes of obstruction, are they all equally as bad?
That's an amazing question, Rida. We have two types: open looped and closed loop obstruction. A simple or open loop obstruction means contents can't pass, but blood flow to the bowel wall is still okay.
I'm guessing that a closed loop obstruction means the bowel is blocked at two different points, but I still don't understand the difference.
Think of it like a tunnel. In open loop obstruction, one side of the tunnel is blocked by an accident, so the cars keep piling up behind. The traffic is slow, but the roads are fine. In a closed loop situation, both sides of the tunnels have collapsed, and the cars are stuck inside. Pressure builds up fast. There's no way to escape, and eventually the tunnel walls start cracking.
That makes so much sense. So, in a closed loop obstruction, pressure builds up quickly. That pressure compresses blood vessels and the blood flow drops. And now you're heading towards strangulation, ischemia, necrosis, and perforation.
Now you understand why surgeons panic when they see certain CT findings?
So, do all obstructions present the same, or can you localize the obstruction before imaging studies?
Yes, symptoms can often help us locate where the obstruction might be. In the case of proximal obstruction, early in the GI tract, causes early vomiting, which is often bilious, sometimes projectile. There's less distension, but the patient looks sicker and more dehydrated. Can you guess what distal obstruction would look like?
Oh, I know. Distal obstruction is the opposite. Vomiting is late and it can be fecaloid. There's marked abdominal distension, constipation, or obstipation, anorexia, and a delayed presentation.
You've said it perfectly.
All right then. So far, we have been defining and differentiating. Let's now walk through the actual pathophysiology.
I got you. So here's what happens nothing can move forward, so everything upstream starts to pile up. The bowel stretches and distends, which raises the pressure inside.
That pressure will then compress the blood vessels in the bowel wall, reducing blood flow.
And without enough blood, the wall becomes injured and swollen. That's edema, and fluid starts leaking both into the bowel itself and into the abdominal cavity, which we call third spacing. Even though the belly looks bloated, the patient is actually losing fluid and becoming dehydrated. On top of that, the damaged wall becomes leaky to bacteria, which can then enter the bloodstream and cause sepsis.
If this process isn't stopped, the bowel can become ischemic, then necrotic, and eventually perforate. So, bowel obstruction isn't just uncomfortable, it's a race against time.
Exactly. That cascade explains why bowel obstruction can become a surgical emergency.
We all know by now that any diagnosis starts with history. What are some important questions or complaints to keep in mind for this case?
First, consider the patient's age, as certain causes of bowel obstruction are more common in different age groups. Next, ask about past medical history and comorbidities.
Conditions like diabetes, hypothyroidism, or neurological disorders can contribute to functional obstruction or even pseudo obstruction.
Then, review medication history carefully. Medications such as narcotics, antipsychotics, or anticholinergics can slow gut motility and mimic or worsen obstruction. Don't forget past surgical history, especially abdominal surgeries, since adhesions are one of the most common causes of mechanical bowel obstruction.
We should also inquire about previous similar attacks. Recurrent episodes may suggest chronic partial obstruction or underlying motility disorders.
Chief complaint matters. It gives us vital clues.
Can you tell us a little bit more, Maryam?
Colicky abdominal pain, caused by the bowel contracting against the obstruction. Nausea and vomiting, which often follow the pain. As the bowel fills with fluid and gas, the abdomen gets distended, and patients can also experience obstipation, or failure to pass stool or gas. It is usually a late sign. Interestingly, early diarrhea can occur if only liquid stool passes around a partial obstruction.
Let's move on to the next step. What would be our physical exam findings?
Upon inspection,
Please don't give me your proscript. Normally will do.
fair enough, you would find distension on inspection, tenderness and a palpable mass when you palpate, and tympany when you percuss the abdomen. Using your stethoscope, you would hear hyperactive bowel sounds with audible rushes due to vigorous peristalsis in the case of early obstruction, whereas late obstruction gives silence.
That's quite an extensive list.
Guarding, rebound indicates that it is complicated. And don't forget to always check hernias and always do a digital rectal examination.
These make sense, but when it comes to bowel obstructions, what are we looking at in our lab investigations?
Labs are mainly to assess how severe the obstruction is. Look for leukocytosis, which can show inflammation, and hemoconcentration, which hints at dehydration. Also check kidney function. Acute kidney injury can sneak in if the patient's fluid status is off.
Whoa, those are actually big things.
Don't forget electrolytes. Vomiting or fluid shifts can throw them off. And if lactate is elevated, that's a red flag. Think ischemia, and you need to act fast.
Are these enough to diagnose our patient though?
Not yet. We can perform imaging tests to confirm our diagnosis.
So, x rays and such.
Yep, X ray is often the first test we do. It's diagnostic in about 86% of cases, so it's useful, but don't expect it to tell you everything. It's usually non specific. You can see air fluid levels, but it cannot determine the exact cause or the extent of obstruction.
Unless there's a frank perforation with free air. Then it's obvious.
Sometimes we use a contrast study, but that needs a nasogastric tube. The cool thing is, it's both diagnostic and therapeutic because the contrast can help relieve some obstruction.
But none of these sound assuring. Or, what's the word? Specific.
Now, CT scan is king. It's 95% sensitive and specific and can show us the exact site and cause of obstruction, plus any complications.
There we go! But intestines are so loopy and long. How can we identify abnormalities?
Good question. To figure out the abnormal, you must first remember what's normal. You can use the 3-6-9 rule. Small bowel, less than 3 cm, large bowel, less than 6 cm, and cecum, less than 9 cm.
Basically, if X-ray doesn't tell the full story, CT is the way to go. Indications for CT include patients with a history of abdominal malignancy, early post-surgical patients, those with no prior surgery, or if we suspect complications.
Oh, and on CT, look for a transition zone where the dilated bowel suddenly narrows. Watch for closed loop obstruction, a U-loop or coffee bean sign with tapering at both ends, or volvulus, which can show a mesenteric whorl.
I have a feeling we still haven't covered CT scan completely. Is there anything else we should look out for?
Good catch, Rida. CT also helps spot complications, bowel wall thickening over 3 mm, mesenteric edema, fluid trapped between loops, decreased bowel wall enhancement, pneumatosis intestinalis, or mesenteric or portal venous gas. Any of these means the patient might need urgent surgery.
Let's talk about small bowel obstruction. First things first, what are the common causes we should keep in mind, Maryam?
Well, the big one is adhesions, which account for around 60% of SBO cases. Then we have hernias at about 10%, tumors for 20%, Crohn's disease at roughly 5%, and miscellaneous causes make up less than 5%.
60% for adhesions is huge. Any idea why they're so common?
Yeah, most adhesions form after surgery. In fact, about 50% of adhesive SBOs occur within a year post-op, 25% between 1 to 5 years, and the remaining 25% can happen even 5 to 25 years later. They're particularly common after pelvic surgeries, like gynecologic procedures, appendectomies, or colorectal resections.
And what about hernias? Are they usually tricky?
Hernias account for about 10% and are actually the most common cause in patients with a virgin abdomen, meaning no prior surgery. These include internal hernias or abdominal wall hernias. If a hernia gets incarcerated, it can block the bowel.
Got it. And the other one on the list were tumors?
Right, tumors make up 20%, and these can be primary or metastatic, causing obstruction either inside the lumen or from outside, compressing the bowel.
Okay, that's the causes. We already discussed the physiology of what happens when the bowel gets obstructed. But can we get a refresh on that, please?
Obstruction causes upstream distension, raising pressure and reducing blood flow, leading to edema, third spacing, dehydration, ischemia, necrosis, perforation, and bacterial translocation causing sepsis.
Sounds dangerous. How do we manage it?
The first steps are supportive. I'm going to have to list them out, so stay with me now. Nasogastric tube to decompress the bowel, fluid resuscitation, electrolyte replacement, Foley catheter to monitor urine output, input plus output charting, and pain control.
Antibiotics?
Well, that's controversial. Routine use isn't strongly supported unless there's a clear infection.
Interesting. So adhesive SBOs, do we need surgery immediately?
If there's no complication, we start with the non-surgical approach. One method is the water-soluble contrast challenge. Give 100 milliliter contrast via nasogastric tube. Take follow-up x-rays at 8 and 24 hours. If the contrast passes, that predicts resolution. If not, it usually fails and you might need surgery.
So when would we operate?
Well, the obvious one is if adhesive SBO doesn't improve with conservative management. Surgery is also indicated if clinical deterioration occurs, signs of strangulation, such as high WBC, fever, severe pain, and tachycardia. Other causes include tumor, hernia, intussusception, sometimes Crohn's disease.
So basically, any red flags or failure of non-op measures.
Exactly. It's all about watching for complications and lack of improvement. Early recognition is key to prevent necrosis or sepsis.
Got it. So to summarize, adhesions are most common, hernias are critical in virgin abdomens, tumors can compress, and management starts conservatively unless there are red flags. Did I miss anything, Maryam?
You nailed it. And don't forget, timing matters. Adhesions can cause obstruction even decades after surgery, and contrast studies can guide us on who really needs surgery.
Okay, quick breather. If you're still with us, genuinely proud of you. Now, we're officially in the second half of the lecture. This is where things get heavier, but also way more logical if you let the physiology guide you. So, large bowel obstruction, how is it different from small bowel obstruction?
Oh, there are a few key differences. First, the colon has a wider diameter than the small bowel, so it takes longer for symptoms to show up. Second, and this is high yield, when obstruction does happen, the consequences can be catastrophic.
Especially for the cecum, right?
Exactly. The cecum is the widest and thinnest walled part of the colon, so it's the weakest point when pressure builds. Think of it like the balloon that's most likely to pop.
So, when we think about large bowel obstruction, what should be the first thing that comes to mind?
You want to ask two things: how much pressure is building, and where is it going? That's the framework to anticipate complications. Just like small bowel obstruction, we split large bowel obstruction into two main categories: mechanical, meaning there's a physical blockage, and adynamic, meaning the bowel just isn't moving.
Today, we'll focus on mechanical, because that's where most exam questions live. Let's dive in. The number one cause of mechanical large bowel obstruction is colon cancer. We're talking about roughly 90% of cases.
That's why any older patient with new onset constipation, abdominal distension, or change in bowel habits should immediately raise alarm bells. This isn't IBS or diet related, it's obstruction until proven otherwise.
Are there any other causes, Maryam?
Other causes do exist. Can you guess some of them before I list them all?
I know. Inflammatory bowel disease leading to chronic scarring and narrowing. Hernias trapping segments of colon.
You're absolutely right. Then there's volvulus, especially sigmoid, diverticular disease causing strictures, fecal impaction, particularly in elderly or institutionalized patients, foreign bodies, and yes, adhesions, though these are much more common in small bowel obstruction. Here's a high-yield concept. How do we know how dangerous the case is? Well, it depends on whether the ileocecal valve is competent.
Interesting. Can you please break that down for me?
If the ileocecal valve is incompetent, gas and fluid can reflux back into the small bowel, partially decompressing the colon. That actually buys you time. But if the valve is competent, nothing escapes. Gas and fluid keep accumulating, pressure rises, and all that pressure hits the cecum, the weakest point.
Oh, I know. That's where the 369 rule comes in, right?
Exactly. The rule of perforation skyrockets. At that point, it's not if something bad happens, it's when.
How do patients with large bowel obstruction usually present?
Large bowel obstruction is more subtle at first. Patients often have gradually progressive abdominal distension, worsening constipation, later obstipation, which means no stool, no flatus. Pain tends to be less colicky than small bowel obstruction, more constant.
And vomiting?
That's a late feature. Makes sense since the obstruction is far downstream.
So, imaging is key here.
Yes, plain abdominal x-ray may show colonic dilation with haustral markings, but CT scan is the investigation of choice. It tells you the site, cause, and any complications like ischemia or perforation.
Oh, and one more thing. CT becomes especially important when malignancy is suspected. Okay, Maryam, now we know how the patient presents and how to diagnose, but how do we manage a patient with large bowel obstruction?
Before definitive intervention, start supportive care, such as IV fluids, electrolyte correction, NPO, nasogastric tube if vomiting, broad spectrum antibiotics if perforation or ischemia is suspected.
But keep in mind, unlike some small bowel obstructions, mechanical large bowel obstruction almost always needs definitive intervention. Now that we have built the framework, let's zoom into the most exam-loved causes. Go on, Maryam.
Volvulus, pseudo-obstruction, and malignant colonic obstruction.
And if you understand pressure, blood supply, and timing, the rest honestly just falls into place. Volvulus means an air-filled segment of colon twists around its mesentery. But let's pause. What's the mesentery?
It's the bowel's lifeline. It carries blood vessels, nerves, and lymphatics. Twist it, and you block the lumen and threaten the blood supply.
Oh, so like twisting a garden hose with wires inside?
Exactly. That's why volvulus can quickly go from obstruction to ischemia, gangrene, and perforation.
That's scary. So where does volvulus most commonly occur?
Most commonly, sigmoid colon, about 90%, then cecum, rarely transverse colon.
I have been thinking about this. Why does the bowel twist in the first place?
Usually, the colon is long, redundant, and mobile. Chronic constipation stretches it, makes it floppy, and rotation becomes more likely.
So, if you see a case in the exam with an elderly patient, chronic constipation, massively distended abdomen, volvulus should be on your radar. And how do sigmoid volvulus patients present, Maryam?
Classically, they come in with acute large bowel obstruction, progressive distension, pain, nausea, vomiting, constipation, or obstipation.
And what are some important red flags?
If there's fever, tachycardia, leukocytosis, think strangulation, gangrene, perforation. That's no longer a wait and see case.
So, how do we diagnose this?
Easy! A plain x ray would show coffee bee sign, contrast enema would show bird's beak sign. Basically, pathognomic.
Does management depend on viability?
Yes, that is the one key question. If there are no signs of gangrene, perforation, or peritonitis, first-line treatment is endoscopic detorsion. A flexible sigmoidoscope is used to untwist the bowel, and a rectal tube is usually left in place to keep things decompressed.
Sounds simple, but I know that there's a catch.
You know there is. Recurrence is common, up to 40%. That's why once the patient is stabilized, they should undergo elective sigmoid colectomy with proper bowel preparation.
Now, what if the patient comes in sick?
If there's clinical or endoscopic evidence of gangrene or perforation, like necrotic mucosa, ulceration, or dark blood, you skip endoscopy and go straight to surgery. Options include sigmoidectomy with primary anastomosis or Hartmann's procedure.
Now, let's talk about cecal volvulus. Less common, but very important.
There are two main types. One is cecal bascule, where the cecum folds upward without twisting. The other is cecolic volvulus, where the terminal ileum, cecum, and ascending colon rotate together, twisting the ileocolic mesentery.
On imaging, cecal volvulus looks different from sigmoid volvulus, right?
Yes, you're right. We often see a kidney or croissant-shaped dilated loop in the left upper quadrant. A contrast enema can confirm obstruction at the level of the volvulus.
So, coffee bean for sigmoid and croissant-shaped for cecal. Did you skip breakfast this morning, Maryam?
Yes, studying for GI really killed my appetite. Okay, back to volvulus. A high-yield difference worth noting is that there is no role for endoscopic detorsion in cecal volvulus. Management is surgical. The preferred option is right hemicolectomy with primary ileocolic anastomosis. Simple detorsion or cecopexy has a high recurrence rate and is generally avoided.
Now here's where things get sneaky. The colon looks massively dilated, but there's no mechanical blockage.
That's Ogilvie syndrome. It's an adynamic large bowel obstruction due to autonomic dysfunction, and we usually see it in hospitalized, post-operative, or severely ill patients.
And management here is all about going step by step.
Management is very stepwise, and the first question is, are there complications, and how dilated is the colon? If the cecal diameter is less than 12 centimeter and there are no complications, we start with supportive management.
And supportive management means?
That includes NPO, IV fluids, correcting electrolyte derangements, decompression, either with a nasogastric tube or rectal tube, stopping any offending medications, and importantly, treating the underlying cause.
Important caveat time. What if supportive management doesn't work?
Then we move to medical management, as long as there are still no complications.
Which brings us to neostigmine.
Exactly. Neostigmine is an acetylcholine esterase inhibitor. It increases acetylcholine levels, stimulates muscarinic receptors, and enhances colonic motor activity.
How's it given?
It's given as a 2 to 2.5 milligram IV bolus injected slowly over 3 to 5 minutes. It's actually very effective, with a success rate of 60% to 94%, though recurrence can occur in up to 31% of patients.
Uh huh. And can we use this in all our patients?
Definitely not. Neostigmine is contraindicated in mechanical bowel obstruction, suspected ischemia or perforation, patients with asthma or COPD, bradycardia, recent acute coronary syndrome, and renal failure.
Damn, okay. This drug sounds scary.
Yes, neostigmine must be given in a monitored setting with atropine immediately available because of the risk of severe bradycardia.
Okay, so we can't always use it. What else can we do then? Or what if this drug fails too?
Then we move to endoscopic decompression. This is indicated when supportive management fails or there's a contraindication to medical management and there are still no complications.
Will this finally help our patients?
Yes, it's pretty effective. Initial decompression success rates are 61% to 95%, and sustained decompression is achieved in about 70% to 90% of patients. That said, colonoscopic perforation does occur in about 1% to 3% of cases.
I'm still not convinced. What if this does not work out either? Or what if complications show up?
Then we escalate to surgery, failure of all other modalities, or the presence of suspicion of complications like ischemia or perforation. We perform an exploratory laparotomy, and this is important. Laparoscopy is contraindicated in this setting.
Finally, our last stop, malignant colonic obstruction.
It's been a long ride. Let's dive in. Patients with colorectal cancer can present with obstruction, and it's more common with left-sided tumors.
How do these patients usually present?
Typically with progressive constipation, abdominal distension, abdominal pain, and often weight loss.
Management depends on patient stability, tumor location, and available resources.
Options include upfront surgical resection, endoscopic stenting, often as a bridge to surgery, or creation of a diverting stoma.
Oh my god, that was a lot. Let's rewind. Volvulus twists the bowel and threatens blood flow. Sigmoid volvulus gets endoscopic detorsion first, unless it's complicated. Cecal volvulus goes straight to surgery. Ogilvy's looks scary but isn't mechanical, and management is stepwise. Malignancy changes the entire approach.
If you follow the logic, pressure, blood supply, location, and time, the whole lecture clicks.
And that officially completes the bowel obstruction lecture. If you stayed till the end, kudos to you. Ladies and gentlemen, that wraps up today's episode of PodBites.
If this made bowel obstruction feel less scary, our mission here has been accomplished.
We'll see you next time. Until then, stay hydrated and go with the flow even when the bowel doesn't. So, large bowel obstruction, how is it different from small? So, large bowel obstruction, how is it different from small?
There are a few key differences. There are a few key differences.
So, coffee bean for sigmoid and croissant shaped. Croissant? Croissant? Okay. So, if you see a case in the exam with an elderly patient, chronic constipation. Okay, don't stare. Look everywhere else. Okay. Oh my god, that was a lot. Let's recap. Volvulus.
Recap!
Oh, sorry. Oh my god, that was a lot. Let's recap.
Why is the M coming out?
Recap.